Good morning, good afternoon, everyone. Sorry for the bad pun in the title. Here are my disclosures. And we will speak of ultra-high resolution CT. And currently, when we speak of that, everyone is thinking about photon counting CT, which is buzzing in all imaging and even non-imaging congresses. Yet, ultra-high resolution CT is clinically available since November 2017. This is the Canon Aquilian Precision, 0.25 millimeter detector size, 1024 and 2048 matrix sizes with DLR. There has been a substantial amount of publication about the use of this ultra-high resolution scanner, yet it is still largely under-deployed. Of course, because of its cost, because also of the infrastructures needed to carry on with ultra-high resolution images. You need advanced PACs and so on. And in my opinion, the biggest barrier to adoption is that when you go with ultra-high resolution CT, you lose some major advantages of conventional CT. Namely, and first of all, you do not have a wide area detector, which is, when you do cardiac imaging, I think major disadvantages. You lose in gantry rotation, it's only 0.35 seconds, and you lose also in the possibility and the availability of 100 and lower kV, because the recommended usage is 120 kV. So the question is, what if we could overcome this limitation and bring UHR-CT advantages to conventional CT? So this is possible, otherwise it wouldn't have been topic today, and this is called super resolution deep learning reconstruction, aka PIQE, which is the commercial name of the technique. So today, and for the next 10 to 12 minutes, we will try to answer three relevant questions. First of all, what are the evidences for the usage of UHR-CT in cardiac images? How is SR-DLR working, and how can it be applied in clinical routine? And third, what are the developments that we could await from SR-DLR? So first of all, what about the usage of UHR-CT in cardiac imaging? Currently, the researches in UHR-CT imaging are extremely similar, whether using the ultra-high resolution CT or the photon counting counterpart. They focus on the advantages induced by the very thin slice thickness and the increased matrix size, namely the possibility to have a sharper image quality, to have reduced artifacts, mostly reduced partial volume and reduced blooming artifacts, and also the improved detection and characterization of small anatomical structures. And all of this explains that most of the research on the subjects are focusing on either the evaluation of highly calcified vessels or the evaluation of stents when you are looking for in-stent restenosis. There is also a small amount of topics about plaque characterization and quantification. I would like to show you what is, I think, the most comprehensive publication to date on the subject, which has been published last year in Radiologic Cardiothoracic Imaging. It is a prospective single-center study focusing on patients with severe coronary artery disease that were referred for invasive coronary angiography. And the patient had UHR-CT before going to CAT, and the primary endpoint was the diagnostic accuracy of UHR-CT at a vessel level. And when available, a conventional CTA was obtained for comparison. So regarding the acquisition protocol for the UHR-CT, it's relatively standard. Keep in mind that on this study, which has been published in 2021, but acquired in 2019 and 20, the images were reconstructed with iterative reconstruction and not with DLR, which is currently available. So in the end, 15 patients were included. We can say that these are quite challenging patients because they were quite big, 91 kilograms in median, either with stents or either with high calcium score. You can see that the radiation dose was relatively high. And in the end, with comparison to invasive CAT, the diagnostic accuracy of UHR-CT was good to excellent with a sensitivity of 86% and a specificity of 88%. So in comparison, there are data from the Core 64 study in patients with calcium score above 600, where the numbers are worse than this. We can see in the table of the results that there is quite a good correlation between the readings of the UHR-CT and the readings of the CAT, and mostly almost no under-evaluation of significant stenosis in CAT and not significant on UHR-CT. When we dive a little bit into the publication, there are two interesting findings. First, 2 patients also underwent conventional CTA, and in one case, the UHR-CT was able to correctly identify non-obstructive lesions, while conventional CT said that the lesions were obstructive. This is in the illustrations of the article. Conventional CTA, where the reading said that this was significant. UHR-CT, when the reading said that it was non-significant, and the confirmation with the invasive CAT. Second findings is that 3 cases with heavily calcified vessels where UHR-CT was able to correctly rule out obstructive CAD. So there is an interest in using ultra-high resolution CT in this kind of patient, but how is SR-DLR working? So SR-DLR is based on the exact same principle as DLR. So it's based on conventional neural networks, and very briefly, the target images for the training is high resolution acquisition from UHR-CT. The base images for the input are simulated conventional CT images. You train conventional neural networks in the factory, and then you applied it on site to go from standard to high resolution. This is relatively simple. So in a routine CT rotation, it is working exactly as DLR is currently working. It is relatively transparent for the end user. The reconstruction is done on site with a dedicated machine. The reconstruction speed is a little bit slower than DLR, about 2 minutes for 640 images volume, and the impact on workflow is minimal. So what advantages can we expect from the usage of this technology? We have seen an increased perceived image quality with SR-DLR, which in my opinion is due to an accumulation of different factors. First and foremost, you have a noise reduction which is significant, even if you compare it with DLR. You can see here the standard deviation is significantly lower with SR-DLR compared with DLR. Second, you have an increased sharpness, and you can see that the conspicuity of structures and contours are better. For example, here in the mitral valve, this is definitely better than DLR and ER. Even on some subtle lesions, here some faintly calcified cusps in the aortic valve. This is also working in curved MPR, where the contours are better even in the curved MPR. Third, you have a better delineation of small structures, such as the small arterial branches, as seen here, or as seen here. And finally, you have an increased conspicuity of calcification, which means that even low or faint calcifications will be better seen with SR-DLR compared with DLR or ER. So in the end, all these facts add together, and they explain the increased perceived image quality of SR-DLR compared to DLR, and of course compared to iterative reconstructions. So in routine clinical work, in cardiac imaging, the promise of SR-DLR is to bring all the advantages of UHR-CT to conventional CT with lower cost, a higher installed base, of course the ability to use a wide area detector, so one bit acquisition, a faster rotation time, the ability to lose 100 kV, and the lowest radiation dose. So let's see some clinical examples. This is a clinical example of SR-DLR applied to a non-calcified plaque. You see that the DLP is extremely low, and you can have an excellent depiction of the border of the lesions and also on the non-calcified lesions. Here, this is a mixed plaques in the proximal LAD. You can see with SR-DLR that there is an increased conspicuity of the various components of the plaques. All that with a very, very low radiation dose. And here, this is a patient with heavily calcified vessels. And you see that compared to ER and DLR, the blooming artifacts are a little bit reduced. And you can see better the lumen within the curved MPR of the vessel. Here, another curved MPR of the same patient. You see that the radiation dose is lower than what you can expect with UHR-CT. So what are the future development of this technology? So a major development that is currently under study is the usage of a 1024 matrix. So currently, when you use SR-DLR, the end result is in a 512 to 512 matrix. So theoretically, the increased spatial resolution that you can achieve with SR-DLR is limited by this matrix size. So this potential limitation could be overruled if we are able to increase the output matrix size. So with that, the reconstruction is done in the end, and after applying the SR-DLR, you obtain an images with a matrix size of 1024 by 1024. So here are some examples. The example here of the mixed plaque severe lesion in the proximal LAD with 1024 matrix. You can see a little bit better the conspicuity of the lesions. Another example in our patient with a heavily calcified vessel, and you see that within the lumen, it's a little bit easier to tell the components inside the curved MPR with the 1024 matrix. And finally, an example with a stent, distal stent in the LAD. You can see better the component of the stents here and here compared to the 512 matrix. It is working also not for the coronary arteries, but also for the other parts within the coronary CTA, namely here prosthetic aortic valve. And you see that with the 1024 matrix, the sharpness of the borders are much more better delineated than with the 512 matrix. So to conclude, SR-DLR, namely PIQE, in 2022 is an AI algorithm that is designed to increase the image quality of coronary CTA. So for now, it is dedicated only for cardiac CT, and it is usable without any tangible impact of the workflow, and most importantly, no impact on the dosimetry. The acquisition is at the same radiation dose as if you weren't using it. It does increase the perceived image quality of coronary CTA, and most importantly, it could carry a potential impact in diagnostics with possible better assessment of highly calcified vessels, possible better delineation of minimal lesions, and also possible better plaque quantification. So with that, I thank you for your attention.